I think it was a very important session, and I was a little surprised that allogeneic transplantation came up, because most of the myeloma community are not very fond of doing allogeneic transplants. Although when we look at long-term survival, it turns out that it is frequently superior for certain patients than it is to do an autologous transplant, even with the same therapy following the transplant. So in Europe now about 500 allogeneic transplants are performed every year, and we have made an investigation. Gösta Gahrton has done that on 4,000 patients transplanted from 2008. And it turns out that you can come down in non-relapse mortality to something like 10% in upfront patients. And I would say this is relatively new, because usually before, the transplant-related mortality, or non-relapse mortality as we call it, is in the range of 15 to 20%. So this is good news, and with that we can also improve overall survival. So in this large group of patients that we have the condition with treosulfan, which is a key point in this, the 5-year overall survival was 62%, which I think is very good in relatively high-risk patients. So there are good signs in improvement in allogeneic transplants. I think it's important to tell that I don't think that you should do an allogeneic transplant up front in most patients. But in certain high-risk groups with certain specific chromosomal aberrations like del-17 combined with other chromosomal aberrations, for example del-13, the deletion of the chromosome 13, the group by Stefan Knopp and others in Würzburg, they have shown that you can obtain practically the same overall survival in these patients with allogeneic transplants as you can in a population that is not high risk. And I think this is really something very important. The outlook, I think, for treatment of patients with myeloma is very good. I mean, all the new drugs should now be combined with the new approaches, and that means that allogeneic transplant, CAR T-cell infusions of, and also I think a very important cell is the NK cell, which has efficacy against myeloma cells. And here you can probably do CAR NK cells, which is now done, but we know very little about it. I think that, for example, CAR NK cells can be combined with allogeneic transplants, because the CAR NK cell, the early treatment protocols now have shown a high response rate, but also a relatively high relapse rate very soon. And there is room for consolidation with, for example, an allogeneic transplant.